Welcome to the webinar on workforce challenges in humanitarian settings, sponsored by the SAEM Global Emergency Medicine Academy Humanitarian Task Force. My name is Charlotte Roy. I'm a US-based emergency medicine physician with experience in global health and humanitarian response, and I'm co-moderating this session with Dr. Habab Araki. Healthcare workers, as we know, are really at the heart of the health system. The WHO estimates that there will be a global shortage of about 10 million health workers by 2030, and this shortage is obviously much more profound in conflict zones where disruptions to medical training and accreditation, as well as displacements and deaths in healthcare workers, negatively impact the number, distribution, and quality of healthcare workers that are available to provide essential care. We're really thrilled today to have a wonderful panel of speakers who have lived and worked in these settings and who are involved in ongoing research and advocacy related to healthcare workforce issues in the settings that they're from. So we have Dr. Mohamed Hamze, Dr. Omar Mabu, and Dr. Nazreen Shihada. We'll be starting with a brief introduction, then we're going to hear from Dr. Hamze about Syria, next about Sudan, and then Palestine and Gaza. And then we'll close with Q&A, so please hold all questions until the end. Just a quick obligatory disclaimer that the views presented by our panelists are theirs alone, do not represent those of SAEM or GEMA as an organization. And with that, I will hand things over to Dr. Habab Araki.
Thank you so much, Charlotte. Good morning, good evening, everyone, wherever you are in the world. Let us know in the chat where are you joining from. Thank you for joining. My name is Habab Araki. I'm joining today as a co-moderator and a Sudanese physician. To say that conflict doesn't only destroy hospitals, it shatters lives and futures. I have lost many family members and loved ones, not to just actually from the direct violence or even bullets, not because their illnesses were untreatable, but because the healthcare system actually collapsed. There is no hospitals, no oxygen, no electricity, and no safe roads to reach the nearest care. But this is pain isn't mine alone. It echoes across Sudan, Syria, and Gaza. In all of these places, healthcare workers always step forward with almost no resources, no guarantees, and no protection. They do not wait for systems to be rebuilt. They rebuild them every single day. They keep going. They train each other when schools shut down. They stay and they run clinics literally out of tents with amazing resilience and courage. So this webinar is to them and to all of us who care deeply about protecting and supporting those who deliver care in the most dangerous situations. They are the reason why many lives are saved, and they are the reason that we gather here today. So together today, we're gonna hear not just about the challenges, but also about the inspiring solutions that are emerging from within these crises. What is working? What can be scaled? And what can we as a global community come alongside them and support this vital work? And with that, it's my honor to introduce our first speaker, Dr. Mohamed Hamze. He is a Syrian dentist and the health research manager at the Syrian American Medical Society. He specializes in evidence-based humanitarian response and conflict-affected settings. His work focuses mainly on healthcare access, health system strengthening, health workforce dynamics, and the protection of health within the Syrian context. Dr. Hamze, we're so grateful to have you and learn from you. The floor is yours.
Thank you, Habab. Thank you, Charlotte. Good morning, afternoon, everybody, everywhere in the world. It's my pleasure to be with you today with my colleagues to share with you some of the experiences and lessons that I have learned, as well as my other Syrian healthcare workers, colleagues who've been responding to the health needs throughout the crisis in Syria. I'm not going to take long in talking about the conflict itself. Just wanted to highlight that throughout this very long and heavy 14 years that Syria has been going through between 2011 and 2024, and while we are still struggling in a very difficult and challenging transitional phase out of this conflict, I believe one of the key moments that I've realized while I was still relatively younger than now, healthcare worker in Syria in 2012, when we understood that if we are to provide any kind of medical care as support for the protesters who were politically against the views of the Assad government at that time, would be something that will be charged against us and could be getting us even arrested or killed. That was a bad sign that we knew starting from that time. It will be the start of a series of violence and atrocities that will be getting worse and worse throughout the 14 years. Unfortunately, many of these atrocities remained without any accountability to the perpetrators who committed these crimes. And I assume that this kind of precedent that has been made had opened the floor for much worse atrocities and violence against healthcare workers in other crises from that time. And maybe my colleagues could be shedding light on that further on. Sorry, I'm trying to move to the next slide here. Okay. I mean, in numbers, that decision has resulted in more than 3,000 healthcare workers to be killed or to be detained or arrested mainly by government forces. And more than 950 healthcare workers has been documented to be killed while sometimes on duty in their health facilities providing treatment to those in need. When the country and the regime has been changed in December 2024, we realized that many of these who were in detention remained without known fate, which means also that this number of 950 has been doubled, not to say even tripled. Unfortunately, this is the leading theory about the fate of all of these who were healthcare workers and colleagues. As a result of such violence, and if we want to put that also in number, and while looking for numbers about such thing is really hard, I tried to cross-reference some numbers from gray and academic literature, just to tell you quickly that more or less we lost almost half of our physicians before and after the crisis in the last 14 years, 2/3 of our physicians before and after the conflict. We also lost almost half of our allied health professionals before and after the conflict. We don't have accurate information about dentists and pharmacists, but we already know that even before the conflict, we used to have almost half of what is needed compared to relatively UHC-WHO standard, which can be, of course, variant from one country to another, but just to give an indicator. These numbers and all of this drainage in terms of healthcare workers being the country is known in all different conflicts. There has been many factors that were leading to that. I try to group them here in these key points, and I will try to discuss them quickly today. Again, to the violence. The photo that you are looking at is a real photo for one of the doctors of Eastern Ghouta. Her name is Dr. Amani Ballour. She was basically standing in the middle of a tunnel for an underground hospital that has been literally built inside a cave in Eastern Ghouta near the capital, Damascus. This was the only way to transfer the wounded and ensure that there is not a way for them to get bombed while seeking medical attention. This was surreal to the extent that National Geographic put that on a movie that was an award-winning film, because it has been more than 1,077 attacks on health systems in Syria. And this is only what we were able to document. And our estimate for the actual gap is 50%, which give you an idea to what extent this attacks has been severe. We have proven through different research that this attacks has been part of a military strategy to weaponize health, to ensure that, to force displacement of population from their area, to ensure that when you bomb the hospital, nobody will stay near because they know that if they get injured, there will be nobody to treat them. And we also shown that this severely affected ability of people to access the right to get medical attention. So imagine yourself as a doctor suffering from all of these attacks and trying to convince yourself that you need to do something for your community. Not only this aspect of violence, but there are other aspects as well. One of them is this separation of the country to different areas of control. We learned Syrians throughout maybe 14 years to look at our country in different colors representing government forces, opposition, and other factions. And it ended up with having parallel health system with different mechanisms. So if you are a pediatrician, for example, who had graduated from Damascus and looking for a job opportunity, and then you find one in West Syria or Northeast, mostly you'll not be able to get that because of the licensing differences, the recruitment differences, not to mention the security concerns. And this was a big problem because it was already exempting us from benefiting from the remaining healthcare force, even when the times are scarce. This also affected education because, especially in areas outside the control of the government, where there were basically no access to the universities, and here we are talking about half of the population unable to get to the originally established medical institutes and universities. After maybe 5 to 6 years, everybody realized with the continuous drainage of health workforce that they have to do something. New institution needs to be established. And that was very hard because we have no resources, we have no teachers, security concerns, but we have to do something. And this was on the shoulder of different NGOs, local authorities, sometimes even private sector for profit, just to fill the gap of the need with health professionals, even sometimes over the sake of the quality or the capacity of the training of these doctors. If you are a female healthcare workers and working within the crisis, you would have an extra hurdle compared to your other male companions. Sometimes, unfortunately, because of the social construct, it would be very difficult, or maybe it will be less enabling for a female doctor to become in a leadership position, even when she is sometimes the most appropriate one to do that, or even sometimes when she's the only one. I'm here attaching a photo of Dr. Ikram Haboush. She's the head of a maternity hospital in Idlib, and one of the rare, and I emphasize on rare, example of how good it works when you give the power to females who understand what they are doing. That was a problem even sometimes for the population when females having less chance to access opportunities for medical education and ultimately getting in less access to health services in health services where the society assume it should be provided by females. So these are all hurdles that the healthcare workers were suffering throughout the conflict. I want to quickly say how we try to adapt to that. And I cannot stop emphasizing on the importance of the set of beliefs and sticks to the moral values that the doctors in such situation would be sticking to. I personally believe that for many doctors who are still working in these areas, the most of the strength that they are getting is from their belief that there is a duty for us as healthcare workers to provide treatment for those who need it, despite all the challenges and all the risks and all the other opportunities elsewhere. This was really something that has been very remarkable in the Syrian example. I've seen that firsthand, and I cannot emphasize how important this was. In such situation, people collaborate, and the ease of transfer of skills and techniques among doctors was amazing. I think that we are blessed these days with the improvement in technological communication mediums, which enabled us to do more and more remote and online education and mentorship, which would have been not possible maybe 20 years ago. So that was also helping in health worker resilience and adaptation. All of these compact courses provided sometimes within the UN humanitarian response, things like the advanced trauma life support, integrated management of childhood and illness, mental health gap, they have been really beneficial, at least in the early phases when we are trying to bring doctors to understand what are the key standards of response and train them to provide life-saving and emergency response services. Task shifting was also important. I, as a periodontist, has learned to do maxillofacial surgeries because I was at certain times the only one qualified to do that in Eastern Aleppo. I was supported by an ENT and orthopedic surgeon, and sometimes you need to do what you have to do. And I think this was something that needs to be solidified because we were still having this chronic loss of manpower in the health sector over the years. So these are examples, and these are just examples of how healthcare workers can adapt and can try to respond to a very difficult and limited situation where they need to provide aid. But if I want to quickly also talk about those who left, our colleagues who have forcibly sometimes even repelled from being inside the country. Here, 50% translate to almost 15 to 20,000 Syrian. Most of them has went to Germany and Turkey. These are the biggest area of receiving and hosting Syria medical diaspora, among others, of course. The German example was relatively successful in a sense that we had almost 6,500 doctors who has been already integrated within the health system, and we have almost 5 to 10K still in process. That revealed very handy in times of crises such as COVID-19, where every country was looking for additional doctor. It was less successful in Turkey, unfortunately, because of many bureaucratic hurdles, and mainly they were only responding to the migrant health centers that has been providing healthcare for immigrants under the support of Turkish Ministry of Health and the EU. The key challenge is that this remaining part of Syrians who have decided to leave was basically the language barrier, things related to bureaucratic hurdles and accreditation. Imagine you are refuging from a certain country and they ask you for a valid passport and paper from the Ministry of Foreign Affairs, which is not possible. But I think I'm trying to highlight that despite that, they have been integrating into health system and acquiring skill because this turns out to be beneficial later on. After the end of the conflict, and now that Syrians are finally able to regroup back in Syria, the bridge has been re-established between that medical health workforce who has been in the diaspora and that one who has been more or less locked inside the country. And now there is a rapid movement of knowledge share and transfer of skill that is happening on all scales, whether it's from doctors who are just volunteering en masse in medical missions and providing advanced treatments, or those who are supporting the Ministry of Health at the policy level for workforce planning and improving the governance, or even trying to reabsorb the qualifications of those who get foreign degrees outside and reintegrated them into the health system. So hopefully this shows you maybe some glimpse of hopes in the Syrian case that I wanted to end it up with. But of course, there are much things to talk about. I was just limited with the time. Happy to provide any further comments later on in the discussion. Thank you very much.
Thank you so much, Dr. Hamze. That was wonderful. Next up, we have Dr. Omer. He is a Sudanese general practitioner, experienced in emergency medicine, assistant researcher, and a communication officer at the Sudanese American Physicians Association. He previously worked with MSF, Doctors Without Borders in Sudan, delivering care to people affected by the conflict. And we look forward to hearing his presentation.
Thank you, everyone, for having me. Before I start, actually, I really want to preface this by saying that from what I heard from Hamza, we all have the same stories. These are, when we talk about healthcare workers, when we talk about resiliency, when we talk about being there at the face of crisis and whatnot, it's exactly the same struggles and exactly the same hurdles and sad stories that we hear. Different stories, different names, it's just the same capacity and the same reflection of it. I'm really happy to talk to you today about the condition of the healthcare workers in Sudan. As you may know, Sudan has been a very troubled country ever since the 2004 with the Darfur conflict started in the west of Sudan. And then we had so many different hurdles, so many different crises in the west of Sudan up until mid-2023 in April, where another conflict has broke out. Now, before I start talking about the conflict and the details of it, it is really important to say that when the conflict broke in Sudan, it broke in the capital city called Khartoum. Now, why is this important? Because the capital city of Khartoum had 80% of specialized care there. Of the whole country, 80% of the specialized care in the country was centered in Khartoum city. So when the war broke out in Khartoum city, most of these healthcare services rendered and were shut down like immediately after the first bullet. Now, just generally talking about the crisis in general, right now we're talking about that almost 80% of healthcare facilities in conflict zone and 50% of healthcare facilities outside of conflict zones are not functioning. We're talking about more than 603 documented attacks. As Hamza said before, we can speculate. We know from sources, we know from people, associations that are on the ground, but not every case are documented. So we really lack some of these numbers. And we speculate that these numbers are 10 times even worse. We're talking about displacement. 10 million Sudanese people are displaced. And that is on top of another 2 million people who were previously displaced since 2004. We're talking about more than 30 million people are in need of humanitarian aid. And we talk about more than 3 million children are suffering from malnutrition under 5. So what do we know so far? Looking at it from a bigger picture, we're talking about that we don't really have a lot of data about what's going on in Sudan. We have a heavy shortage of specialists. One of my sources, they told me that we are lacking or we lost 70% of specialized doctors in Sudan due to deaths, due to displacement, and also many of them who have actually left the country, which basically right now we are kind of struggling with the brain drain. Most of our specialized doctors have left the country, and that has really decreased the amount of specialized care that the country can provide. Now, as we said before, that more than 80% of the healthcare facilities are non-functioning, and that more than 600 attacks on facilities and workers had been documented. And by talking about all of that, also the medical education in Sudan has suffered a lot. So far, what we know, that researchers say that more than 50%, my resources or my sources, they say that is more than 80% of all the medical colleagues and medical universities have actually shut down. They resumed education in some way or another, be it having partnerships with other centers in other safe states or outside of Sudan, adapting to this hybrid way of learning, whether like doing it on Zoom or actually doing it on hands in other centers that they have partners with. Now, here's something that also Hamza have actually talked about, and he talked about it pretty well. What is it like to be a healthcare worker in Sudan? Now, I'm going to talk about all of these points, and I think they speak for themselves. But from my perspective, when I was in Sudan and when the war started, I was working in the emergency department. And since the first bullet was triggered, we understood that we are in big trouble as doctors and as healthcare workers due to many things. Sudan's healthcare system was not doing well at all way before the conflict started. And it was actually about to shut down, and it was very fragile. But what kept it together was the resiliency of the healthcare workers and society. Sudanese people are very hyper-social and they're very connected, interconnected. So that's why they kept the healthcare system going. But when the conflict started, we were very insecure. We knew exactly that we're going to go into a lot of crisis and we're not secured at all. I personally have been attacked. My department has been looted. And every point here, I have actually been through. I've lived it. I've been displaced twice. My family have been displaced 4 times. We had severe staff shortages to the point where I was not only the only doctor, but I was a doctor, I was a social worker, I was a nurse at times. I had to work as a pharmacist for some reason, basically due to the shortage of staff. We had unequal workforce distribution, economic hardships. Imagine working as a doctor and not getting paid a penny. You wouldn't be able to feed yourself, to feed your family, to even have that sort of a support. And you're 24/7 in the hospital, so you don't really know how to keep yourself going, keep your livelihood going. There's a lot of psychological trauma. I cannot deny that I think I do have a PTSD because of all the airstrikes and all of the bullets that I've heard and all of the dead bodies that I've seen. And my patients that have died from preventable diseases, that seeing them dying right in front of me was really heartbreaking. And there is another thing that is very important, and Dr. Hamza actually went through it, was the politicization of healthcare. Dr. Hamza talked about how all these aspects, the atrocities, the politicization of healthcare are going to set or have actually set precedent in that kind of practices. And we've seen it in Sudan. I've seen it. If I go from a place that a specific faction was controlling and I was providing the health services there, if I go to another faction, I'd be interrogated. Who are you? Why did you work? You're not supposed to treat that person. You're not supposed to treat this person. So that is the direct attack, not only on us, but on our ethics as doctors and healthcare professionals, that health is for all, and that we are here not just to work, we're actually preserving life. And with these practices and making healthcare more of a pawn in politics have actually rendered our ethics to a major distant. Now, again, what is it like? I'm going to talk about my experience as an emergency physician, and I think many of you have actually seen emergency departments. Now, the ED is a very special place. I'm not trying to downplay other specialties or other departments, but the emergency department is a very special place due to one main unique thing, is that whatever that happens in society, we are very well acutely aware of it. If there is malnutrition somewhere, we're the first people to know. If there is an attack somewhere, we're the first people to know. If there is an increase in gender-based violence, we're the first people to know. So being a healthcare professional in the ED department makes you well aware of whatever fast and one set of change that took place in society. And obviously, as Habab said and Hamza said, war is not just bullets and wounded people that come to your emergency department. War actually shatters and shreds the very fabric of society in many different aspects. There are so many cofactors that war actually start presenting to you in the emergency department. What I have personally seen, I've seen the amount of malnourished children that I've seen was unprecedented. I've seen a father who was having psychosis and couldn't sleep for 3 days because he saw his own daughter being raped in front of him and he couldn't do anything. I have seen a mother who lost her vision because of emergency hypertension just because she couldn't access to her medications. I've seen a girl of 12 who, when she came to my emergency department, was pregnant. And when I asked, her guardian wasn't her parents. When I asked her guardian, she told me that she was a foster child and she was raped. And that really left a dent in my heart. And I really didn't know how to handle this. I've seen a boy of 14 who lost his ability to walk because when the war started, they lost their source of income. So this is child labor, right? The little boy had to work, had to start working to provide for his mother and so many other stories. But one thing that I want to say is that I still mourn the deaths of so many people, not only my family members, not only my colleagues, but I still mourn the deaths of so many patients that have died from preventable diseases. I've seen mothers who have died from postpartum hemorrhage, something that could have been dealt and treated. I've seen children dying because of dehydration. I have seen people dying from sepsis. So that was very difficult to handle. Sorry if I'm being a bit emotional, but it brought in a lot of things in me. How is it like that within all these crises and with everything that I've said, that doctors in Sudan have actually managed to keep the system going, or at least some of the services? It is exactly how Hamza actually said it. And I don't really want to add in, like, to say the same things that you said, but I'm adding a bit more or less of the same points. In every department that you work in, especially in the emergency department, you see a lot of your colleagues, whether nurses, lab technicians, physicians, pharmacists, they actually take shifts in roles, right? If your lab technician is there, she is the person who can actually take some blood samples in your ED. If there's a pharmacist, he's the one who's going to be administering some of the medications. I sometimes, or most of the time, I work as a social worker, not only treating patients and managing them, but I actually have to talk to parents and I have to talk to actual patients and making them feel comfortable and making them feel safe. So there was a lot of task shifting going on. And that's how somehow our emergency department and a lot of emergency departments around the country have actually maintained their services to some extent. There is also trying to make the best out of whatever tools that you have. I cannot really confirm nor deny that I have used a plastic bottle and an IV line and somehow created a makeshift chest tube just because I didn't have a chest tube. I cannot confirm nor deny that I have actually had to do a paracentesis with no ultrasound guidance. So many of the doctors and many of the healthcare professionals, they really had to, and they're still doing it, they really had to be very quick, very knowledgeable. They had to make sure that their clinical knowledge and on-hand experience that should come like at the forefront of everything, because definitely with the lack of imaging tools, with the lack of any kind of tools, as I just mentioned, we didn't really have chest tubes. So I made a chest tube out of a plastic bottle and an IV tube. There's also this sense of responsibility and social responsibility. A lot of the doctors, a lot of the healthcare workers, we don't really work for the sake of working. Most of the time, it is just to serve the people, to serve our families. It is well known that whenever a person comes, healthcare professionals, Sudanese healthcare professionals treat them as if they are part of the family. And that's what kept their resilience going. Faith played a huge role, social fabric played a huge role, as well as grassroots efforts and grassroots organizations. Ever since the war started, many of these bodies, we're talking organizations on the ground, neighborhoods, board members and whatnot, they all came together to actually try to fill some of the huge gaps that were already happening before the war, and then the bigger gaps that took place right after the war. what you see right now is Dr. Safa Ali. She's an obstetrician. Dr. Safa had all the resources in the world to leave Sudan, but she didn't. She stayed in the heart of the war, in the heart of the conflict, delivered thousands of babies under airstrikes, under bullets, and she kept going. No matter what, a lot of people, I know a lot of people who tried to convince her to leave, but she didn't, and that she stayed. She was actually nominated or actually mentioned as one of the world's 100 most inspiring female doctors. These are the things that are happening right now in Sudan and outside of Sudan. We're talking about diaspora engagement. There are many rehabilitation of facilities that are going on right now. As I mentioned before, hybrid medical education systems, mobile clinics and outreach, and as well as humanitarian coordinations with other orgs and whatnot. So what do we have to do right now? How can we move forward? So it's the same exact thing that Hamza mentioned. We are partnering diaspora organizations like SAPA. The organization that I work with right now have actually started sending EMTs to Sudan to provide specialized care. And to the people here, if you are interested, you can always reach out to us at the Sudanese American Physician Association and be part of these emergency medical teams, convoys to go to Sudan and provide specialized care there. There are many efforts in rebuilding health infrastructure. I'm actually also calling upon all the other organization associations. I know that SAMS and SAPA had previous relationships before, collaborating together, trying to make sense of whatever that's happening and try to rebuild the healthcare system, as well as amplifying the crisis, because you guys, as you may know, that Sudan hasn't been talked about in the media as usual. And that really affects the kind of attention and the kind of support that Sudan might need in the future. Thank you so much for hearing me out, and all the best.
Thank you so much, Omar, for this powerful presentation and for giving us a lot of emotions. Thank you for that. It's now my pleasure to introduce our next speaker, Dr. Syrian Jihadi. She is a healthcare professional and current master's student in public health at Imperial College London. She earned her bachelor in dentistry from the University of Palestine. She was displaced from 2024 due to the ongoing war. Nisreen, we're so honored to have you today with us. Please go ahead.
Thank you, Habab, and thank you, Charlotte, for having me today. Thank you, Mohamed, for basically summarizing a lot of what's happening even in Gaza. And it's really sad how all of these conflicts in different countries, in different settings, are still the same. I could relate to what Omar mentioned a lot as someone who lived in Gaza after October 7th, who lived in Gaza for my entire life, who was displaced multiple times, who still have family there. It's really sad, it's really affecting, but I think we are here also today to share awareness, talk about what's really happening and what we can do more. So regarding Gaza, there's a lot to talk about Gaza, honestly, but I'm gonna start talking about how nothing has started in October 7th, and I think this is something that we all should focus on. The whole Palestine, the whole country has been under occupation for 75 years, and Gaza specifically has been under the blockade for 17 years, since 2007. And living under a blockade for 17 years has affected all aspects of life, especially the health system. Health workers are operating or has been operating under extreme pressure, the lack of power, the chronic supply of shortages, the movement restrictions, and of course the isolation. You are not allowed to travel in and out of Gaza, and this can affect the education process, the training process that our doctor and our health workers need. And of course, this has led, even before October 7th, again, in 2023, 40% of essential medicines in Gaza were out of the stock. Hospitals were working on or relying on 4 to 6 hours of electricity. The referral system has been disturbed multiple times. And of course, after October 7th, 2023, the situation has deteriorated in a catastrophic way. The systematic targeting of the hospitals and the health structure in Gaza has deeply affected everything from the health workers to the people on the ground, to the patients, to the injured people. For now, as I'm speaking, more than 70% of hospitals in Gaza are damaged or destroyed. There has been more than 400 attacks on health infrastructure, according to the WHO, with major hospitals. We are talking about hospitals that the whole strip are relying on, like a Shifa hospital in Gaza City. For example, that hospital has been targeted, sieged, destroyed more than 12 times since October 7th. We're talking about a period in less than 2 years. Of course, we're talking also about other hospitals in the strip, like Al-Nasser Al-Adwan hospital that I'm going to mention later today, which left entire areas in Gaza Strip without any functional hospitals. We're talking about the north of Gaza City, who has been left without any functional hospitals, who still has population who are still targeted, who are still displaced, without any functional hospitals. And this will lead, of course, to overcrowding to other medical points, overstretching or adding extra pressure on the health workers who are in the ground. Of course, as I mentioned, the systematic targeting on health infrastructure and the hospitals in Gaza has led to operational collapse. Also, there's another thing that I want to talk about, that since October 7th, I talked about the blockade before October 7th, but even after October 7th, there was already a lack of supply on many medical equipments, on many medical tools, on many basic stuff. And after October 7th, this has turned into complete blockage of entry of medical equipments, which led doctors, people on the ground, health workers, to operate surgeries without anesthesia, without sanitation, without supplies. As I mentioned before, the hospitals have been destroyed, which led to other hospitals or other medical points to be overcrowded. They have reached more than 300% of bed occupancy in some areas. I honestly don't know what to say, because there's a lot that our doctors, our health workers have been witnessing, from operating surgeries in tents on the corridors of the hospitals because there's not enough beds, to performing surgeries again without anesthesia. This has been a pattern in Gaza lately. Most of the patients have not been treated because there's not enough treatment. There's no anesthesia, there's no medications. And sadly, the reality now in Gaza, if you are injured or if you are under treatment, it's more likely for you to die than being treated, not because we're not operating, but because honestly, there's nothing that we can do at this point. And I want to talk here about something that's not mentioned a lot in the scenario of Gaza, which is how training has been disturbed since October 7th. The medical school and dental schools in Gaza, the main ones, have been destroyed. We had 2 medical schools and 2 dental schools. Both of them have been completely destroyed. And it's just not only destroying the health system, they are only destroying the pipeline of the training, the pipeline of the next generations who can join the workforce, which lead the current workforce, the current health workers in Gaza under severe pressure because they have been targeted, they have been killed. There's not enough numbers in the strip right now. There's not enough specialists. And the people who were supposed to be in the ground for 2 years now are being denied from their rights to do. Talking about mental health, honestly, I don't think I can do this topic its justice just by talking about it. What I already mentioned, I think it's enough to draw a picture of what's really happening and what our doctors have been seeing. I'm quoting here a colleague, Dr. Azzeddin Lulu. He's saying, in Gaza, we operate for 15 hours straight. No food, no water, no breaks. Doctors are collapsing, not just from fatigue, but from starvation. Our patients are starving, so are we. And yet we keep going because someone has to try to keep others alive while the world looks away. More than 90% of people in Gaza have been displaced, including medical staff and trainees. Many are forced to choose between treating patients and protecting their own lives. And when we are talking about healthcare workers, we don't want to forget that these are also citizens. These are also the people on the ground who has also been displaced, who has also been suffering, who has also lost their lives, their family members. And they are also been going through what their patients are going through. Currently in Gaza, there is a massive starvation. People are being starved since March, and doctors have been affected too. The health workers on the ground have been affected too. And for us to expect them to stand and still give while they are being starved, while they are being fatigued, without any kind of support, without any kind of break, is just out of this reality, to be honest. I'm talking about this as my own dad is a doctor now in the ground, my own mother as well, my younger sister. They are all going to their hospital every day to perform, to help patients while they are being starved. And it's honestly heartbreaking to see what our doctors, what our health workers, when they are supposed to be treated, when they are supposed to be honored, are living in such a reality. And of course, I think today my main mission here is to give my voice for the doctors who have been targeted, for the health workers who have been kidnapped, for everyone on the ground that felt they are a target just because they are in the health system in Gaza. The numbers on the screen are not only numbers, they are representing health workers, they are representing people who stood in their work in the front line to protect their patients. They refuse to leave. They refuse to let the patient die, and as a result, they have been killed. More than 1,200 Palestinian healthcare workers have been killed by Israeli occupation since October 7th. They have been detained. More than 300 people, Palestinian healthcare workers, have been detained by Israeli occupation. 4 of them have been killed in detention, and 24 of them, they went missing until this day. And I'm sure maybe you've seen this picture before of Dr. Hussam Abu Sofia, who is facing the tanks. And I'm here today to talk about his story and shed light on what our doctors, our healthcare workers have been living since October 7th. Dr. Hussam Gaza North Hospital Kamal Adwan through a prolonged siege and bombardment. After weeks of being sieged, targeted, and threatened, a drone strike on the hospital entrance killed his 15-year-old son. He had to bury his son in the courtyard of the hospital. After months of holding the hospital together, he was arrested in December. Imagine, after months of being in a hospital, targeted, threatened, he lost his son in front of his eye. He has to bury him in the backyard of the hospital. And he was injured as well. He finally was kidnapped in December. By July 25, his lawyer has said that he had lost over 40 kilograms and he had beaten, tortured in isolation, and denied necessary medical care. This is not an isolated incident. They are part of a broader pattern of targeting healthcare workers across Gaza. Sorry if this was heavy, but I really have to talk about this because this is the reality of what's going on. This is how our doctors have been targeted. And I feel like this space, or I have the responsibility to use my voice to talk about these stories, to talk about our doctors who have been working non-stop since October 7th, 2023. It's been over more than 2 years for now, and our doctors, our healthcare workers have been facing the same scenarios, have been targeted. But of course, as Omar and Muhammad mentioned, and I think I'm gonna mention the same points as they said, because surprisingly, in our countries, despite everything that's happening, we are still resilient. We still have this resistance to the occupation, to the destroying of our healthcare systems. We still refuse to let our patients die despite everything that's happening. Health workers draw strength from each other in Gaza, from faith, from sumud, Palestinian philosophy of steadfastness. This is not an individual coping, it's a collective resistance. Doctors in Gaza rely on each other. They have peer support. They share a meal when there's no meals. Even shared silence between shifts become a way to carry on for them. They hold grief together, and that's what allows to keep them working. I'm also gonna mention something that Omar has said. In Sudan, they have turned into alternative ways, unusual ways, just to maintain the work, just to keep the workflow going. And this is exactly what's been happening in Gaza under the lack of power, under the lack of equipment, under the lack of medications. Doctors have found themselves making instant decisions. They are not supposed to make it in any usual scenario, but they have found themselves in unusual scenarios and where they have to act immediately, and they have succeeded in that. They are the ones who are still holding our healthcare system till this day. But I have to mention here that their resilience is not a substitute for protection or justice. It's a response to injustice, and these doctors should not be starving, hunted, or tortured. Their strength must not be an excuse. And our responsibility here is to support them, to speak up for them, and fight for a world where resilience like this is never needed again.
Dr. Shihada, you have about a minute left.
Yeah, I'm almost finished. Lastly, I'm gonna say what we can do to protect healthcare workers in all the world, including Gaza. We have to emphasize that healthcare workers must be protected in all scenarios. Training must be resumed. Recovery must be led by Palestinians with international solidarity, not control. And above all, there must be an end of violence now. Thank you.
Thank you so much. That was really amazing. And you have been a voice for healthcare workers in Gaza, as you all have been for healthcare workers in your individual settings. It's just such an honor to have you all here today to speak to what's going on in these different contexts. So we'll open up now. We have a few minutes for questions. If anybody has a question they'd like to ask, please put it in the chat. In the meantime, if there are no questions right at this moment, I'll start. So we talked a lot about things like task shifting and emergency response teams, different types of things that can help people adapt when working in these settings. A good number of people in the audience are emergency medicine physicians or other health workers who are looking to help. And so what can we do to be supportive in these settings, particularly with a focus on any innovations related to medical training or medical education?
But Hamza, you can go for it if you want to.
I'll try to answer as much as I can to this. I just want to say that task shifting seems inevitable in most of the contexts where we are facing a constant lack of number of physicians who are specialized in specific kind of interventions or needs to cover the gap of the health system. So even though in Syria we are phasing out of conflict, until we are able to properly prepare and train healthcare professionals who are able to cover that gap, this will be still inevitable. There has been even some kind of models happening in different countries that we are trying to learn from, sometimes even providing this kind of skills to community-led initiatives to be able to provide that even in a more sustainable or low-cost setting. But I think also now, as I said before, the availability of ways to learn through e-platforms is making this sometimes easier and easier. With some kind of mentorship and proper guidance, this could be, if properly planned at country level or a nation level, really a solution that could fill this gap on the midterm and a short term in such countries. Hopefully, this shouldn't be a permanent practice, but I think that this could be something beneficial for any country who are still in active conflict or phasing out of a conflict.
I see there's a question in the chat as well. This person said, in Syria, doctors reported that the main cause of psychological trauma is the difficult decisions they were forced to make during wartime due to severe resource shortages. For instance, limited number of intensive care beds, high number of patients forced doctors to make decisions about who should be given the limited opportunities to survive. Is this the situation in other conflicts?
Definitely. As I said before, like we although like we have different names, victims have different names, it's different countries, right? We're talking about Syria, Sudan, and Palestine, but it's the same thing. When it comes to healthcare services, when it comes to the collapse of healthcare system, people have to make very hard decisions. I personally made a lot of hard decisions and it's very difficult for a doctor. Let us put this in perspective, right? We're here to preserve life. And when you are pushed to the point where like you really have to choose someone over the other due to lack of tools, due to lack of equipment, due to power cuts and all the different and the crisis, whatever that the crisis brings you, when you're pushed to that corner and you are the decision maker of who gets to get treated and who gets not, that puts a lot of pressure on you. And I told you before, I am still mourning the deaths of so many patients because of some of these decisions. And it still has a psychological trauma. I left Sudan a few months ago, but I have an AirPods, right? And this one has noise canceling function. I got it just because I could sleep at night. That's how it's hard. This is to that extent the psychological trauma does to you. We're resilient. As Nasreen said, resilience is not a substitute for protection nor justice, but it's not enough. Resilience is not enough. Resilience comes in with people, with tools, with equipments, with protection. Not only that we want to be protected, but we want to be protected so we could be able to protect our patients.
Thank you so much, Rama. There is another question in the chat. How feasible to talk about and emphasize preventive measures in such crisis contexts? It's from Amen. Feel free to unmute.
Can I take that? If I want to talk about preventive measures, I look to this in two levels. We have the operational level where it should be the responsibility of all of those who experience working in such horrific situations to try to document what they have been going through and try to extract lessons learned and share that with other conflicts and contexts where we are obviously sharing similar situations. This is something, for example, that we try to transfer our knowledge and expertise at some time to our colleagues who have been responding in the Ukraine due to the conflict out there. Unfortunately, we had experience in responding to chemical weapons, which is something that you don't learn a lot. And we came, at the end of the day, people who are trying to share these recommendations with others. But there is a more, let's say, higher level of policy that the best prevention for this is not to have that in the first place. It's sad that I am, as a doctor, needs to be learning how to respond and build underground hospitals and manage scarcity of resources rather than trying to stop these atrocities in the first place. And in order for all of us to work on this and convince the politicians, it's very important to learn how to document these atrocities, try to build case files of all of these attacks and try to systematically and in a professional way document that and try to seek accountability and justice for all of these crimes that has been committed in the hope that at a longer term it will be possible for us to reverse this trend of increased violence against all international treaties and conventions protecting healthcare. We are not going in the right direction right now, but hopefully with an increased efforts in advocacy and knowledge sharing among all of these who are subjected to that, we can maybe aspire for a better future later on.
I think we'll end there since we're over time. Thank you so much to all of our panelists and to my co-moderator. It's really been just amazing hearing from you and inspiring and also tragic and heartbreaking, but gives us a lot to think about how we can try to improve things in these settings moving forward. And we're just really grateful for your time. So thank you for being here, and thank you to our audience for listening.
Thank you.
Thank you all.
Thank you, everyone.